Good day, ladies and gentlemen. My name is Philipp from Gottberg. I'm a neurologist at the Stuttgart City Hospital in the town of Stuttgart in Germany. And today I'm going to talk about drug-coated balloons for neurovascular indications. First of all, what's the issue? Stroke and death are mainly caused by atherosclerotic disease of craniocervical arteries. And the main reason for stroke worldwide may even be intracranial arteriosclerosis, with up to 38% at ethnic differences, so higher in the Asian population and lower in African ethnies. We as interventional neuroradiologists have means to treat atherosclerotic vessel disease. However, large multi-center trials could yet not prove the superiority of our treatment options towards invasive procedures as the surgery, carotid artery surgery, or even medical therapy for intracranial arteriosclerosis. And therefore, in the neurovascular setting, we still lack the proof of a benefit from the interventional treatment. Why is that? A main reason in the leading trials that some over 10 years ago was the high risk for symptomatic restenosis following intravascular treatment, which is probably up to 40% in 5 years for the internal carotid artery and up to 66% in 3 years for intradural artery restenosis following treatment. What's the reason behind that? Actually, the reason is mainly excessive mesenchymal proliferation, which is caused probably, or which is very likely caused by the very mean of treatment in the first hand. So the stents that have been applied or the balloon PTA that is irritating the vessel wall, especially the stent strouts, may cause this excessive proliferation, therefore causing the restenosis. And in cardiology, this problem is also well known, and this problem also appeared, and it has been challenged well with introducing drug-coated balloons and drug-coated stents, drug-coated devices, in a way that now in international guidelines, drug-coated balloons are an option of choice. This benefit in cardiology has not been shown in the neurovascular setting yet. It is presumed, but still data on that is sparse, and I think this is highly under-investigated, and I'm going to show in the upcoming slides what there's to find about in literature. What are drug-coated balloons? Actually, it's just a balloon catheter that is coated with an excipient and a cytostatic drug. The excipient is the medium that brings the drug to the vessel wall. And if you have a look at this picture, this is an zoomed images on several kinds of balloons. On A, you just see a plain balloon before inflation. B is a balloon after drip coating, which was the way of creating a drug-coated balloon in the early days when there was not yet industrialized production. You can see that there's some little spots on this balloon. This was a first way of coating a balloon, still very ineffective. And in C and eventually in D, you can see industrialized production, industrialized produced balloons with a very smooth, and especially in D, with a very homogeneous coating. And in these balloons, a relevant transfer of the drug to the vessel wall is achieved. There's different kinds of cytostatics that can be used. The most common still is paclitaxel. And there's different kinds of excipients, so the medium that brings the drug to the vessel wall. And this is a crucial part, since also in the cardiology guidelines it is always highlighted that the recommendation of using a drug-coated balloon is not for the class of this device, because there's so many differences in the effect of different devices which are believed to be caused by different excipients. In this table, I've summed up all current devices that have CE marking, and you can see that the main drug on them is PCX, paclitaxel, in different dosage. There's some few ones that have sirolimus, and there's a lot of different excipients, as you can see in this line here. And these excipients, as I just said, may play the key role in the effectivity of the device. Let's have a look at the drugs that are used. Paclitaxel is a cell death-inducing microtubular drug that interferes during mitosis. It has shown to be highly effective in the hindering of neointimal proliferation in coronary arteries. And a good thing about it, an advantage of paclitaxel is that it is highly lipophilic, which makes it quite secure since it doesn't solve in water, and it should actually stay where it is applied to without being washed off, solved chemically into the blood that surrounds the vessel, that flows through the vessel. Sirolimus, on the other hand, is a cytostatic, non-cytotoxic, but cytostatic drug that also interferes in mitosis. It has a much broader therapeutic range. It is believed to be milder since it's only inducing cytostasis, not cytotoxic, since it's not cytotoxic, and it has greater success in restenosis treatment than other anti-restenosis drugs. However, due to its chemical structure, it is much more difficult to bring sirolimus to the vessel wall, and therefore paclitaxel still is the dominant drug in the drug-coated balloons. When talking about all these drugs, I mean, these are drugs that are also used in oncology, and one question that quickly arises: what happens to the drug on the surface of these balloons if it is washed off? Is this actually an issue? Yes, it is an issue, and this was highly discussed in some trials, some studies years ago. We know that quite a lot of the drug on the balloon is actually lost in action. So up to 30% is already lost en route to the destination. It is sheared off, it is washed off in the catheter. Up to 70% is the highest share, may be lost directly after balloon inflation and deflation through washout, just mechanically being washed off the balloon by the blood flow. And up to 30% actually may remain unapplied on the balloon and may just go into the trash bin afterwards without any therapeutic use. So actually the coating on the balloon is it's suffering a huge loss, and there's only a small part that can actually be applied to the vessel destination, to the vessel wall. And what happens to this tissue, to the tissue that is behind the part where we applied our drug-coated balloon? Especially it's about human brain. Actually, we don't want to have a local administration of an highly cytotoxic or cytostatic drug. Still, there's no data about the effect of paclitaxel or sirolimus on neurons after stenosis treatment through DCB, because there's just not enough data. But if we do look over the line and just look at oncology, we know that the single dose in oncology is about 300 milligram for paclitaxel, and at the dosage of 70 milligram per square meter body surface or higher, this is the dose where peripheral neuropathy will start. If we look at the complete amount of paclitaxel that is on a drug-coated balloon, and if we get into the worst case scenario with all the numbers I just showed you in lost in action, around 8.6 milligram of paclitaxel would actually be available for downstream effects, which is way below the amount of drug that may be able to cause peripheral neuropathy. And that's the reason it is believed to be safe. And there's actually a lot of in vitro studies in cardiology and in vivo studies in peripheral angiography that have not been able to prove any negative effect of the wash off of the drugs. In cardiology, in peripheral venous disease, this is still discussed, but still in cardiology, non-negative effect has been proven by the wash off of these drugs, either from stents, not from drug coating balloons. So let's get to the application in the neurovascular setting. The main locations for the use of drug-coated balloons are, of course, the parts where the atherosclerotic disease mainly shows up. So this is, of course, the internal carotid artery at its origin. It's the intercranial parts, the medial cerebral artery, and the posterior circulation. It's the vertebral arteries. It's the basilar artery. There's very few case reports about treatment of the subclavian artery with a drug-coated balloon, and there's nearly none no data about treatment of the external carotid artery So I will skip these in this presentation. There's just not enough data on that. Maybe there will be some in the future. Well, it's not yet. Let's have a look at internal carotid artery. The treatment of the internal carotid artery stenosis, arteriosclerotic stenosis, there's still a highly discussed. It's under ongoing investigation debate which method is better, so open surgery or the transluminal approach. It is still yet not clear which one is better, and especially for drug-coated balloons, there's not yet a large database that is dealing with the primary use of DCB. So the main treatment so far that has been described in literature is the treatment of restenosis following surgery or following transluminal angioplasty. If we keep in mind that the 5-year cumulative risk for restenosis following treatment is about 30% for the PTA, for the endovascular procedure, and about 40% for the open surgery, well, we can have a look at what's available to investigate in the literature. And we can see that actually with the treatment of drug-coated balloons, we have a much lower rate of restenosis than initial stenosis. This is difficult to compare, and also if you have a look at the treatment numbers in the first line of this table, you will see that data is really sparse on that. However, for example, in the study carried out by Pullman in 2017, we have this follow-up time of 5 years, and actually here the event-free rate is much better than in the PTA treatment with 83% of non-symptomatic follow-up of patients receiving treatment through drug-coated balloons of internal carotid artery restenosis. Also in the other trials, in the other studies, small case studies, mostly single-center studies, the results are in favor of the drug-coated balloon treatment. Still, one has to admit, this is far away from large multi-center trials, and these are mostly just single-center trials, and data is very limited. Still, all of these trials actually are in favor of the drug-coated balloon, and this may encourage to further investigate drug-coated balloon usage in the internal carotid artery treatment. For the vertebral artery, there's no discussion anymore about open surgery or endovascular treatment, of course, because of the fact that it's just too difficult to access for surgery. Here, still current consensus is that medical therapy as first-line treatment should be applied, but actually there's no real data that proves that the endovascular procedures are inferior to that. There's just no superiority proof yet. This is still a region, part of the neurovascular setting, which is crucial. Up to 25% of cerebral ischemia cases may be caused by arteriosclerosis of the vertebral arteries, and due to the fact that this is the posterior circulation, they're connected to a much higher morbidity and mortality than in the anterior circulation. And this table sums up what's available to investigate in literature. I've summed up all the studies that are available so far. With 88 patients, actually there's a very low periprocedural complication rate, and even though the follow-up is short, 7.5 months, the restenosis rate for the treatment of arteriosclerotic disease of the vertebral artery, first-line treatment, is actually it's quite low, and this also encourages to investigate further in the treatment of first-line treatment of arteriosclerotic disease of the vertebral arteries. Wang et al. In 2021 even investigated whether there's advantage in bare metal stenting versus bare balloon treatment with distal embolic protection, and they found comparable results for both methods, which actually is not in favor completely of the drug-coated balloon, but also shows that the endovascular approach may be superior to the pure medical approach. Intracranial use of drug-coated balloons. I've combined anterior and posterior circulation. Since the Sampras and the Visit study, 2011, 12, 2015, research into the treatment of intracranial arteriosclerosis treatment, interventional treatment, has been decreased sharply since these two studies so impressively showed the superiority of the medical treatment. And again here, to line out, the reason for the bad results was the high rate of restenosis following the treatment, which is mainly caused by neointimal hypoplasia as a main issue. And actually this is the exact field that a drug-coated balloon can do well in, and still even more like in cardiology, where the leave nothing behind doctrine meanwhile is getting much more into focus. This would be a part where if we think about stent shrouds irritating the vascular surface and then causing restenosis, this is the part where the drug-coated balloons as primary line treatment may be doing well. If we look at data available, there's few data in which drug-coated balloons were used in first-line treatment, and actually they have a much better result for this short-term follow-up than in the Sampras and the VISIT trial. So in a total of 181 patients and a follow-up of up to 11 months, the restenosis rate was 6%, which is definitely much lower than in the 3-year follow-up rate of up to 66%, and it's still below the Sampras and VISIT data for the same time of follow-up at a very low periprostheral complication rate. So this actually speaks very much in favor of drug-coated balloons. There is no worry about stent shrouds that would irritate the vessel wall. This is a very uncomplex kind of treatment. This is safe, it is quite easy to perform, and since there is no need for platelet inhibition, this is also probably a much higher acceptance for the patient, and this definitely encourages to do further investigation of first-line treatment of intracranial arteriosclerosis. If we have a look at the treatment of restenosis through drug-coated balloons, also these few studies from 2011 and 2020 with very few case numbers and a short follow-up, one has to admit, still speak in favor of drug-coated balloons, and therefore also this really encourages and advocates the further investigation of this device in the neurovascular setting. So for summing up and comparing also with different methods of treating atherosclerotic disease in the neurovascular field, this table sums up data from literature regarding drug-eluting stents, bare metal stents, bare balloon, PTA and surgery. And here, with the cutoff of few data, sparse data, still we can see that, for example, the periprostheral complication rate alone in the first row here is actually is very low. It's speaking very much in favor of the drug-coated balloons. As I said, it's a quite easy procedure, and especially compared with surgery for the external carotid artery, a drug-coated balloon angioplasty has a much lower complication rate. And if we look at the restenosis rate also here in 26 months, this is summing up all the studies I've just shown you, we are still below the rate of 12% in 12 months, in 20 months for external carotid artery surgery, speaking very much in favor for drug-coated balloons. And these benefits actually, these go on in the different sections of the neurovascular setting, the vessels in the neurovascular section, and also in combination or in comparison to drug-eluting stents or bare metal stents, they speak pretty much in favor of the drug-coated balloons. And therefore I think this is a highly under-investigated topic, and especially due to the fact that the Sampras and the VISIT trial in recent follow-up trials and recent multi-center trials are getting much more into discussion and actually not questioned much more. I think there will be a development towards endovascular treatment of atherosclerotic disease in the neurovascular setting. There will be a rethinking soon, since I think we will be seeing studies with much better results that are then showing the superiority of this method, and I think drug-coated balloons will play a much higher role in the future. Thank you much for your attention. These are my references, and now